Hello and good afternoon, everyone. My name is Deborah Johnson Ingram, here with our team from PCDC, Primary Care Development Corp, and our friends and partners over at Streamline. And we are really happy to present to you folks today. We're slowly waiting for participants to join the session, so give us a couple of minutes as they all flow in, and we will get started in 2 minutes after the hour. And meanwhile, I'll do some sort of housekeeping. We typically like to have our participants engage with us. So what we'll do is we'll have that chat feature available for everyone as you flow in. If you have questions specifically to one of the speakers, you can go ahead and chat that. We will be monitoring the chat and responding as needed. If you have questions and our session is almost over, don't worry, we will get your contact information and reach back out to you. We will try to ensure we answer all questions that are asked throughout the session. And if you need to speak, everyone is coming in and they're on mute, except for our speakers. So if you do need to speak, good morning, Wendy. If you do need to speak, you will be able to raise your hand. There's a raise hand feature on your Zoom. I'm assuming most of you know where that is, but it's at the bottom of your screen. It's typically in the black band, and it literally has a hand that looks like this. And you'll click on that, and then our facilitators will get you able to be unmuted. You can unmute yourself, and then you can go ahead and speak. So we'll alert you when you are open to speak. But we want to have an engaging conversation, so we're looking forward to having you all engage and chit chat as we go on with the session today. Slide. I'll do some more housekeeping around Primary Care Development Corp. As many of you already know, we are an organization that was established as a CDFI. What does that mean? We were started as a lender. We lend to organizations that are partners like the ones that are joining the session today. So we have leveraged in the past 30 years, 1.3 billion in financing with our partners, mostly federally qualified health centers, but we are expanding our partnerships and lending to other organizations besides federally qualified health centers. We're definitely in the space of lending towards behavioral health organizations and other mission-aligned entities. We provide capital and services in 43 states, including Dominican Republic, Puerto Rico, Washington, D.C., and the Virgin Islands. And we've created or maintained $2.2 million square foot of clinical space. So that allows even more access to healthcare services, especially for our vulnerable communities. What? Some of the other work that we do, obviously, besides us being the lender, is why we're here. We are a training and technical assistance organization. Our partners in Clinical and Quality Partners team are here to assist and support your organizations, improve access, improve HIV and AIDS prevention and treatment services and our capacity building programs. We help train and educate on care coordination, care management. We support those who are struggling with their EHRs and trying to utilize those to the best that they can. We help support value-based payment performance improvement, quality improvement, patient-centered medical home, obviously, meaningful use, MIPS, which is now QPP, the clinical performance programs with Centers for Medicare and Medicaid. We help improve programs, operations, and revenue cycle. Next slide. Information on how we do our lending. So if those of you who are interested in that lending product, please feel free to email us directly. Our contact information will be on your last slide. All of this information, by the way, our slide deck and the recording will be made available to this entire registered group. So don't worry. And I'm your host, Deborah Johnson Ingram. Our speaker today will be Anuja Solanko, and she will introduce herself very shortly. Shannon Lee, Rachel House, and our partners Deborah at Streamline, Will Richardson, will be presenting at the closeout. Next slide. So what are our objectives for today? We wanted to have a conversation about patient-centered medical home. Many of us have been doing this distinction program, this recognition program, since its adoption from NCQA back in 2008. So it's been a long time, so over a decade of many of us doing this work. So we wanted to talk about what are the considerations as we continue on this journey. We're doing annual renewals, but what else does that mean besides doing the annual renewal? What are those key components that you need to be ready for as you prepare your survey? We wanted to actually discuss the revenue cycle management component of it. So what are the critical elements of your PCMH panel that now attributes or has an impact on your revenue cycle? We also want to discuss about the questions on the ROI of achieving PCMH. So many of you may not have sort of touched upon that, but we want to bring that into our discussion for today. And then we thought it'd be great to highlight a vulnerable population. Several of us in New York State, because of New York State's patient-centered medical home, this program had to identify a vulnerable population and do some work and to improve the quality of outcomes for that population. So we have our friends at Streamline talking about an example group that you can all easily lift up and support. Next slide. So now I'm going to turn it over to my colleague, Anuja, but I think I have a quick poll. Next slide.
No, it's actually after mine.
My bad.
Hi all, my name is Anuja Solanko. I'm one of the senior program managers at Primary Care Development Corporation. I work on the training and technical assistance team. I hold my CCE, my Certified Content Expert Certification in Patient-Centered Medical Home. And I just want to say thank you for joining, and I'm super excited to be going over why we're here and going over some of the key metrics for annual reporting. So what is annual reporting? So once you've done a full submission, or what we consider an initial submission, and for those of you located in New York State, that's 52 core criteria and 25 additional elective criteria, you will now be eligible for annual reporting, which is your maintenance of PCMH recognition. Practices must attest annually to continuing a subset of PCMH criteria, which requires documentation. That documentation could be in the form of data, which is reports, evidence, which is either screenshots or policies. And what's nice about annual reporting is that it's significantly reduced rigor when compared to the initial recognition. So it's not 52 core criteria, it's literally 1 to 3 different components under each concept. Next slide. Okay. These are the 6 PCMH concepts. They are the same for the initial PCMH recognition and for annual reporting recognition. They are team-based care, population health management, patient-centered access, care management, care coordination, and care transitions, and the last one being performance measurement and quality improvement. Again, each of these, we will be submitting at least 1 to 3 different measures under each of these 6 key concepts. Next slide. Okay, I want to pause here because this is where we're going to spend a lot of time chatting, I'm sure. So some updates for 2023 is heavily based on reporting. So I would say about 90% of the 2023 submission is reporting based. There are a bunch of different reports that we want to focus on, and just some key factors that you should consider when picking your reports. Your denominator has to be more than 30. For any report that you submit to NCQA, the report has to be 30 or more. 0% is never going to fly. They are looking for us to be at 80% or more now for almost all of these measures listed here, with the exception of the first and second one, which I'm about to cover in a second. Those have little asterisks next to them. Those have mandatory thresholds. The other ones are, we expect you to be at 80%, right? So if you're at 75%, 70%, that's okay, as long as we put in a very valid reason of why we're not at 80% and what we're doing as a team to get to that 80% threshold. So now let's kind of jump into this list here, up-to-date medication list. The expectation is that we are at 80% or more. It is not going to fly if we're at 78%. It's not going to fly if we're at 79%. 80.1% or more for this measure. A lot of EMRs have this report, a lot of them don't. So if your EMR does not have this pre-built report, we can do a manual chart review where we select 30 random patients, go into each chart and see whether that medication list was updated and reviewed. That second measure here is care plans. Slightly different. In the previous years for annual reporting, we've always been focused on who are the eligible patients for care management. They're kind of upping this measure now moving forward. Now they're looking at, of the patients that were eligible for care management, how many of them had a completed care plan? And again, there's an asterisk here, so we need to be at 75% or more. If you are not at these minimum thresholds for the first and second measure, you are risking losing your recognition. I just want to stress that. And if you have any questions, definitely feel free to use the Q&A feature. One of us will be typing in the responses. The next report here is patient visits with clinician or care team. Again, the expectation is 80% of the time that the patient comes in, that they are being seen by their PCP or their care team. What we're looking for is a report. So we're looking at total number of unique visits within that given reporting period, over your numerator being how many of those visits did the patient actually see their PCP. And then of course, that quality improvement worksheet. One other thing I wanted to mention before I jump into the QI worksheet here is NCQA is becoming a little more rigorous in reporting periods, and the expectation is that we are submitting a full calendar year. So as of this year, you can definitely kind of get away with submitting a 90-day reporting period at minimum, but starting next year, they are looking for us to be submitting a full calendar year. So starting in 2024, the expectation is that we are submitting all of 2023, January to December. And now for the QI worksheet, we're submitting 5 clinical quality measures, and they have to align with 4 categories. That is immunization, 1 immunization measure, 1 preventive measure, 1 chronic or acute measure, and then 1 behavioral health measure. Your 5th clinical quality measure is a freebie, as I like to call it, as long as it aligns to one of those 4 categories I just mentioned. And again, we want to find our sweet spot. We want to be between 80 to 99%, right? We also don't want to be at 100% because then they're going to come back and say, well, what's your quality improvement initiative when you're at 100%? And we don't have one because you can't be more perfect than 100%. So you're trying to find your sweet spot between 80% and 99%. The next category is 2 resource stewardship measures. That's really broken down into 2 different categories. The first one being 1 care coordination measure, such as closing the referral loop. And that second category being healthcare cost measure. So this one could be avoidable ED visits, generic versus brand medication. You have a couple of options that we can help you brainstorm here. And then the last one is picking a question from your patient experience survey, as long as that question aligns with, one of these 4 categories: access, communication, care coordination, or whole person care. The important thing here is that I say QI worksheet, but there's no worksheet. So this is all a manual submission in QPass, where you're going to be going in, typing out numerators, denominators, and descriptions. But it's still important that we kind of keep track of where we are with things and what we want to submit. So we're still going to recommend that you guys complete that QI worksheet so we can kind of track progress and where we are and where we need to spend some time. I see some questions coming in, but I think, Deb, you're answering them. Great, thank you. Next slide. Okay, we're not done. There's more reports. Surprise, surprise. Okay, so that first one, diversity. We're looking for race, ethnicity, and 1 additional aspect of diversity. That additional aspect could be marital status, insurance status, housing status, employment status, any of the SDOH factors really, but we could help brainstorm, that additional aspect based on what your EMR is capable of running. One important thing to note here is language and gender do not meet the intent of other aspect. That's not going to work. They are going to push back and they're going to ask for more data. Another important note is 2024 is around the corner. We're already in April, the months are flying by. In 2024, we are mandated to submit gender identity and sexual orientation. It's optional for 2023, but mandatory for 2024. So if your practice is not documenting this, now is the time to implement it. So come 2024 annual reporting, we have these reports readily available. Another report I wanted to cover was appointments outside business hours. Well, let's start off with what is outside business hours? You know, we normally think of outside business hours as 9 to 5, Monday through Friday. Well, NCQA's definition is outside 8 to 5, Monday through Friday. So what we're looking for is a report here over a given reporting period, the total number of appointments over the number of appointments that were actually outside business hours. There are a couple of options if you do not provide outside business hours that we can kind of help you with brainstorming how we can meet this one. If you are not open, let's say on a Saturday or after 5, definitely let us know and we can help support you in meeting this metric. Next slide. Okay. TCO1, shareable involvement in quality improvement meetings. I wanted to pause and really go through this because I've done a handful of submissions already for this year. And there seems to be some gray area. There seems to be some confusion around this one. So I wanted to pause and kind of go over it. It's a shareable criteria. So if you have multi-sites going in, we're only looking for evidence for one site. And what we're looking for is that the entire staff is getting together to discuss quality improvement initiatives. We're not looking for the quality improvement leadership team. We're not looking for a subset of people. We're not looking for just the PCMH team, you know, coming together, discussing QI. It's really looking at staff involvement. We're talking MAs, front desk, your nurses, your clinicians, everyone's coming together on a regular basis. And what's nice here is that you define regular basis, whether that's weekly, monthly, quarterly, or you define your own, you know, time frame here. It could be biannually or annually. You get to choose that, but you are consistently coming together to discuss quality improvement initiatives. Ideally, we want 3 things being discussed in this meeting. 1 clinical quality measure, 1 resource stewardship measure, and 1 aspect of the patient experience survey. And so I'm going to pause here. I see there are some questions. I think Deb's been answering a lot of them, but I wanted to open it up to any specific questions you guys have on anything that I've covered so far.
And Anuja, we do have a few questions. The first one is from Denise. She would like you to go back and repeat. In her example, if her reporting period is in January 2024, which many of you are, obviously her reporting year is the previous year because she's submitting in December because her anniversary will be January. So she wanted for you to repeat what will be that look back period when she's doing her reporting. And I had mentioned it will be the previous calendar year since she is on a calendar year rotation. Denise, did I answer your question? And you can feel free to chat. As you're waiting for Denise to answer that, Teresa, did you have anything else in addition to mention that 80% threshold, although arbitrary, it is dictated by NCQA. They do understand and recognize a lot of their partners are federally qualified health centers, but this is not an FQHC designation. It is an NCQA patient-centered medical home designation, and therefore UDS metrics that are below 80% in terms of your performance may not be accepted without a really good explanation as to why that threshold is not met. However, when they indicate that the threshold has to be 75% or more, like in the care plans, if you submit 74%, they will decline on giving you your recognition. So that's why that 30-day period is so necessary, just in case you fall into that category whereby you have to repeat perhaps chart reviews so that you can find that threshold being met when you're doing your care plans. So I'm going to go back to see if Denise's question was answered.
I think for the sake of time, Deb, I'm going to turn it over to you, and then I will continue answering questions in the chat.
Okay,
And
we're good.
there's
Yes.
always go ahead.
Yes, we're going to get to everyone. Don't worry, we're going to get to everyone. We're going to get to everyone. Denise, we're going to get right back to you. So we're going to move on to the next slide. Here is my poll. Many of us do have patient-centered medical home incentives. Please tell us whether or not your state has incentives. We have folks from all over the country. Does your state have PCMH incentives? These are extra dollars that come to you, whether from the health plan or from the state itself, because you are recognized. Right. And if you don't mind, please chat in the chat your state. It'll be interesting for all of us to see how many states are covered in this conversation. So chat your state. 79% of you do have PCMH incentives in your state, and 21% of you do not. So it'll be interesting to see the states that are now listed. Next slide. So now we're going to turn over to Shannon, and she's going to talk about revenue cycle management as it relates to PCMH. Shannon.
Thank you, Deb. Hi, everyone. My name is Shannon Lee, and I'm a senior program manager on the clinical and quality partners team. I joined PCDC in 2022 to support the needs of primary care and sexual and reproductive health partners. And I have over a decade of experience working in public health as well as revenue cycle management. Next slide, please. I would like to start by defining the revenue cycle, which is made up of all of the activities that lead to payment for services that are rendered. It includes patient registration, verification of benefits, care delivery, claim submission, and reimbursement. Ultimately, the revenue cycle is the financial process that is associated with the patient's clinical encounter. And it's critical for organizations with PCMH recognition to have sound revenue cycle management processes and procedures, because they improve operational efficiency, streamline value, and can positively impact care delivery as well as health outcomes. Next slide, please. So the critical elements of the revenue cycle and revenue cycle management are pre-registration, registration, charge capture, claim submission, remittance processing, insurance follow-up, and patient collections, all of which are listed on this slide. And just going into detail about these critical components or elements, the revenue cycle begins with pre-registration, which is a time when office staff collect information such as insurance coverage before the patient's visit. Outside of insurance coverage, this is a time when staff should ensure that they have the patient's correct address for follow-up. And this could also be a time when you collect a signed acknowledgement of financial responsibility. Registration, which can take place either before the visit or at the time of service, is a time when your staff should verify all of the information that has been collected during pre-registration and ensure that it's correct. So once this information is collected, your team should begin the insurance eligibility verification process, which is the process of verifying a patient's insurance coverage and benefits prior to their encounter. Insurance eligibility verification is critical to RCM because when it's done correctly, it automatically increases your clean claims rates and it decreases payment turnaround. Additionally, having a streamlined insurance eligibility verification process solves major issues like delayed payments, billing errors, and non-payments. So to track your organization's proficiency when it comes to pre-registration and registration, think of tracking key performance indicators like the number of claims that are on hold for registration errors, or even the number of statements that you see each week in the returned mail. And then moving on to charge capture, this is the component or the practice of healthcare providers documenting and recording rendered services so that charges can be submitted for payment from a patient or insurance provider. Capturing charges at the point of care or time of the visit is essential because the further a clinician gets from seeing a patient, the greater the risk for error and lost revenue. A key advantage of capturing charges at the point of care is that it prevents undercoding and missed revenue opportunities. So having clinicians document charges quickly allows them to decrease the reimbursement turnaround, and it also strengthens revenue integrity. So higher revenue capture isn't the only advantage. When physicians correctly enter charges for their patients, your practice can more accurately monitor performance and provider productivity. So to identify gaps in charge capture processes, consider tracking charge lag and also work through the development of policies that call for 24 to 48 hours to complete charts. And then also kind of moving on to claim submission, this involves sending information to the payer once charges are entered. So before submitting claims, your team should always make sure that they're verifying charges, CPT codes, diagnosis codes, the date of service, the place of service, and any provider information, as well as units and modifiers. So anytime that a claim goes out, you will receive a remittance that advises on payment. And prior to posting payments, your team should always make sure that they are reviewing the allowed amount, the paid amount, the patient responsibility amount, and any contractual adjustments. So if you're tracking your organizational health related to claim submission and payment posting, I recommend monitoring your rejection rate, your denial rate, your net collections rate, and your time of service collections rate. And the next component of the cycle is insurance follow-up. And I just encourage you to remember that revenue waiting to be collected is revenue lost. So this component of the cycle is key because this is the point where your staff review not only what has been paid, but also what hasn't been paid. And you can use your accounts receivable reports to determine how much of your receivables are outstanding and how much of what is outstanding is actually collectible. So using these reports to calculate your days in AR, as well as let me just say AR, accounts receivable, and your significantly aged AR, which would be your accounts receivable over 90 days and your accounts receivable over 120 days. This information will help you create plans for follow-up and prioritization that are based on age and dollar amount of your claims. And then finally, the final component of the revenue cycle is patient collections. And I just want to state that the best time to collect money from a patient is when they are in your office. So all of your front desk staff should be trained on how to collect money at the time of service, as well as on how to discuss the topic of past due balances with patients. Having standard policies in place that define how copays and deductibles should be collected are essential to making the collection process easier for your team. So to track success in patient collections, again, I recommend monitoring your time of service collections rate. Next slide, please. As an organization with PCMH recognition, it's key to identify opportunities for revenue. So consider the impact of transition support fees, care coordination or care management fees, and even billing for transitional care management or behavioral health services. So as you are on this journey, remember that billing and coding for all things medical can be nuanced, and it's key to review your historical reports and identify any coding and billing trends, as well as to examine any challenges that your team faces, creating action plans based on the data that you analyze. Additionally, research and encourage your revenue staff, your revenue cycle staff to pursue education and training opportunities related to billing and coding. Training is a great way to reinforce alignment with goals and values, as well as expand and encourage creativity. Position your team for success. And if you determine that there is a need to hire new medical billers or coders, think through whether it makes sense to require certification and how this may benefit your organization. Ultimately, identifying and executing process and operations improvements in your revenue cycle leads to efficiencies in the areas of cost, quality, and cash flow maximization. Next slide. So as I wrap up this portion of the presentation, I would be remiss if I did not discuss the end of COVID-19 flexibilities and the overall unwinding of Medicaid that is now taking place as a result of the end of the PHE or public health emergency. So I really encourage you to consider the fact that you will likely see a decrease in some of your panel sizes and plan for that revenue related impact. Determine which elements of the revenue cycle where you may need to beef up your processes and procedures, So for example, as we expect for changes in patients' eligibility, be sure that your front desk staff are clear on the fact that all insurance eligibility should be verified prior to the date of service. And I encourage you to consider creating a script that allows for standardized explanations of these changes and their impact on benefits. Also, ensure that someone's tracking your claim submission specifically for Medicaid patients, and monitor your rejection and your denial rates, as well as the turnaround time for payments. You know, historically, we've seen that larger scale changes can significantly impact the revenue cycle. So really just making sure that you're taking a look at previous forecasts and projections so that you're proactive in mitigating that negative impact. And so I don't know if there are any questions that have come over in the chat. That wraps up my portion. So Deb, do you want to jump in here and move on?
I'm reviewing the chat now.
Okay.
Any questions regarding the revenue cycle component? We have a lot going on in our country as things are changing. Any questions on the RCM? I still see questions on the PCMH. We'll definitely get back to that. Okay.
Okay.
So we're going to transition now to Rachel, and she's going to talk about budgeting and the ROI for your PCMH. I'm going to have another poll in here, but think about how are you monitoring for those of you get incentives. How are you looking at those numbers coming through? What are you using those resources to help support within your organizations? And Rachel's going to talk about how you can see that clearly and easily within your organization. So, Rachel.
Yes, thank you for having me. My name is Rachel House, and I'm a senior project manager on the Clinical and Quality Partners team. And my focus is really on financial literacy and financial performance. So next slide. So what's the bottom line, right? How does PCMH recognition impact a practice's financial performance? And the short answer is really it varies, and it can vary significantly. So while PCMH recognition has many benefits, such as increased utilization of primary care, improved quality, and better outcomes, it's important to consider the financial implications of recognition and ongoing maintenance, because financial performance can vary. There was not a lot of research available on the ROI of PCMH, and in fact, NCQA engaged Milliman, a respected provider of actuarial services, to research and publish a white paper as really a first comprehensive study of the business case for PCMH. And this white paper is available on the NCQA website, and I encourage all those interested in learning more about the topic to access this information. And a lot of it will be summary kind of in my presentation today. So, so again, because it varies, there's some important factors to consider. So the location and size of your practice, as we mentioned, can vary widely amongst what state you're in. So it's important to understand those factors. The payer mix and payment models available to you is going to be another significant factor. As well as sort of the current state of your practice. You know, where are you starting from? What mechanisms and infrastructures are already in place and necessary really regardless of PCMH recognition? For example, having an EMR in place, team-based care model, et cetera. And then also the culture and bandwidth of the practice to adopt and maintain recognition. What additional resources might be necessary for investment? Those are important factors. Next slide. So when we consider the potential sources of revenue, one thing to keep in mind is that adopting PCMH can positively impact patient access, reduce no-show rates, and improve productivity. And this can all lead to an increase in revenue under a traditional fee-for-service model. However, in addition to fee-for-service model, there are also many other sources of revenue, alternative payment models available. Most do require PCMH recognition, but not necessarily, not all. And again, this varies widely by state. So some of the most common ones may be a per member per month, a PMPM addition to fee-for-service, a performance incentive, as Deb asked in the poll question, There's also potentially program development funds or lump sum infrastructure payments to adopt a new EMR in some states, et cetera. But I think what's critical to understand is the resources that are available in your state and with the payers that you're contracted with, and to understand how those programs work in a detailed way. You can ask questions such as, how frequently should you expect to receive these types of payments? Will be issued as a separate payment or bundled with other payment types? It's really important to understand how you'll be receiving this additional revenue and track that revenue as a separate line item in your financial statements so that it's clear for you to monitor and track ongoing. Next slide. So aside from revenue, the other side of that is the costs, right? And it's difficult, it can be very difficult to tease out the PCMH associated costs from your regular operational costs. So there's two main sort of methods for doing this, activity-based costing and incremental costing. So I'll briefly describe it here, and then on the next slide, I'll try to show you an example of this. So activity-based costing really is about determining the PCMH-related activities. Then you would estimate the amount of time it takes to perform these activities on a monthly basis and the cost associated with that time. So the salary of the staff member who's performing those activities. And this is really useful for, one, understanding how much time you are spending on PCMH work, as well as the activities that you are doing. But it may not necessarily provide the full financial picture. So in the incremental costing method, you would actually consider whether you would incur this cost if you were not undertaking PCMH, and you would only be including costs that are actually new costs. So from a salaried staff perspective, their time is not really additional costs because you're going to be paying them a salary whether you have PCMH recognition or not. You're maybe just redirecting their activities to different tasks. One call out here is to think about staff burnout, right? Are we simply asking staff to do more in the same amount of time, or are we providing them additional resources in order to achieve the tasks that they're being asked to do? So it's just important to consider staff burnout and turnover as sort of a hidden cost, perhaps. And then additionally, so the example of incremental costing that you would include is, for example, a clinician's time. So the time that they're spending on PCMH activities is they are not necessarily seeing patients during that time. So the cost is actually the lost revenue that you're not billing on a fee-for-service perspective while they're doing that work. So on the next slide, we can see, so it's probably hard to read here and it's a lot going on. So I just want to highlight a few things. This is also in the Milliman study, and it's I felt like it was interesting to look at it side by side. So on the activity-based costing side, we can see that we're looking at the staff members' time, again, describing what they're doing and the amount of time that it takes to do that per month. So for example, a lead clinician, they're spending time on a monthly basis to serve as the champion, to set the tone for the practice and how they will function as a medical home. And for the initial recognition, they estimate 10 hours per month at $120 per hour, plus fringe benefits, and that's how they calculated it. And then on a maintenance or annual reporting basis, that drops down to 4 hours. I should point out in both of these models, they used a hypothetical practice with 10 clinicians, 20,000 patients, or an average of 2,000 patients per panel. So that was the sort of model they were looking at for these examples. On the incremental costing side, that lead clinician's time is actually calculated again by looking at 20 visits per month at $110 per visit. And that's how they're calculating the cost of that clinician's time in the incremental costing method. Whereas with the PCMH manager lead, you can see that it's actually zero in the incremental costing method. They're not counting their time because it's salaried time. But they are in the activity-based costing model. The care manager or care coordinator that's highlighted in the red box, that position was a new position that the practice hired, actually 2 new positions for PCMH recognition specifically. So the full cost of their salary was used to calculate costs on both models. So there's a lot of similarities and some differences with both models. I circled the bottom just to show that there's not that much difference between both models. It's slightly higher in the incremental costing method. Both use considered training and NCQA recognition fees were the same in both models. So both approaches are beneficial, and you kind of have to figure out which one would work best for your practice. Next slide. So here I'm just including this. This was another study done primarily looking at small and medium-sized practices. And they're showing here that the initial phase of recognition, the cost per provider sort of peaked somewhere between $25,000 and $40,000 per year. And then it sort of drops down and levels off for ongoing recognition and maintenance, but it's still somewhere between $15,000 and $30,000. So it can be a significant investment even to maintain recognition. So and smaller practices might have a slightly higher per provider cost, just kind of due to economies of scale. They're going to spend a little bit more per provider generally. But the bottom line is it's really important to track this because it can be a significant investment even to maintain your recognition. And finally, on the next slide, again, it's important to create a budget and to calculate the ROI of this work. So we can do that by assessing our sources of revenue and review current contracts to clarify all of available revenue models. Track that revenue related to PCMH reimbursement as a separate line item within your financial statements. Assess expenses related to initial recognition and ongoing maintenance using either the activity-based or incremental costing methods. And finally, you'd want to create pro forma financial projections by year and include contract terms as those can change and impact your financial picture. So ultimately, in the Milliman study, they found that there was generally a positive financial impact to practices. However, how much and to what extent can vary significantly. So it's important to analyze and monitor it on a regular basis.
Thank you so much, Rachel. Next slide. And these are her references. So I thought that was a great conversation because we typically only talk about PCMH, but these other pieces that our organization's financial leadership want to know and understand as we continue down this pathway of patient-centeredness. What does it cost us? How are we monitoring the revenue? Are we adjudicating our claims and making sure we get the highest pay in those fee-for-service environments, but also addressing acuity and documenting appropriately the need for patients needing care management? So here in our poll, are you budgeting and forecasting for PCMH? This is a safe space. We're just curious because a lot of us, when you ask the question, it's like, not that specifically, not that dynamically the way Shannon and Rachel had mentioned. So give us an idea of whether or not your organization is budgeting and forecasting for PCMH. And as we wait for those poll results, we're going to, okay, we got the answers. Okay, 21% of us is a yes, congratulations. 79% of us, it's a no. So that is telling. It is definitely an area in which we've heard, and this is why we've got our team, Rachel and Shannon, on board at PCDC, and that's because it was something that's not being said, but it's said, if you know what I mean. Our organizations can't afford to do quality improvement because they don't know where the money is going and flowing. And that is a bit of transparency that would benefit a lot of us who are working in the QI arena. But we need to understand how we need to quantify and measure it. So we're going to turn it over to our colleagues over at Streamline. And I want to make that transition by making a statement that PCDC says most often, that patients that constantly no-show demonstrate a vulnerability. And we know this, especially in our communities that are marginalized. There are things that get in the way for our patients to be able to do something such as literally get to a doctor's appointment. Even though they called and made the appointment, there are things that get in the way from them doing that. So Streamline's going to talk, Will at Streamline's going to talk a little bit about his organization, the work that they've been doing in supporting no-shows in the community practices that they've been supporting. Will?
Yeah, Deborah, thanks so much for having us. We're excited to partner with you on this front. And yeah, just to reiterate what Deborah was saying, Streamline is a partner of PCDC, is not the same as PCDC, but we, as Deborah and her team does, serve largely the federally qualified health center market. And we essentially create tools that help you all kind of identify, track, and reduce patient no-shows. As Deborah was mentioning, kind of a no-show is one of the, lowest common denominators of identifying a vulnerable population. If you have patients that are making appointments, but if you're not showing up that much, that's a key indicator of, hey, maybe this patient has barriers to care and you should figure out how to best get them in. So next slide, please. I think this is kind of just a level setting slide. We all know the costs of patient no-shows. I think they're costly to everyone. For the center, their missed revenue, it can mean, the difference between being financially stable and unstable. From the patient perspective, that's care that they, didn't receive. It's also an appointment slot that was filled. So it's not just the patient that didn't show, it's also the patient that couldn't show. So it's almost two patients that don't receive care when there's a no-show. And then, of course, it's providers that are underutilized. So those, costs are pretty common and known. If you go to the next slide, what I was mentioning earlier is this bit, is that it's just a little bit less known of how much no-shows reveal about specific patients within your patient population. Working with federally qualified health centers across the country, we've actually identified that the no-show problem is pretty concentrated. So about 10% of a practice's no-shows are attributable, or about 50% of a practice's no-shows are attributable to 10% of their patient population. So, it's generally not, most of your patients kind of having one no-show every now and then. It's really, a concentrated percentage of the population that's just continually no-shows. If you pop over to the next slide, the biggest thing, we've done with groups is just helping them identify those people and helping them easily, know who they are, know how often they're no-showing. And what's a key component, working collaboratively with them to see, hey, why aren't they coming in? What can we do to, better make them have a chance of getting in? So, we're identifying if there's a transportation need, if there's a work-related need, if, it needs to be switched to remote. So one of the ways we work with federally qualified health centers is to ingest all this information and to just present it to you in a simple and easy and actionable way. We know it's difficult to do, all of this work around becoming a PCMH. So one of the things Streamline tries to do is just take some of that work off your plate. Let us do that hard work and just, allow you to do the work that actually touches the patients. But we'll do, the data software work. Then the next slide, another key piece of this, in the context of, hey, how do we, get more patients in, reduce the impact of no-shows, increase patient access? One of the things we've learned is that a lot of FQHCs do overbooking today, but they typically don't do it in the most strategic way. A lot of their providers, understandably, don't love the practice, but it's pretty important to overbook just to maintain financial stability and to always be seeing patients. So one of the other solutions we offer is a predictive model that was built by a few Johns Hopkins data scientists that'll tell you specifically in your schedule where you're likely to have no-shows, and then recommends overbooks in those slots. The model is 90% accurate, meaning if we make a recommendation, 90% of the time there will not be a patient conflict. So, for a lot of practices, FQHCs that use this, You see patient lead times go down. Patients can come in sooner. You see providers more accepting of the overbooking practice because their schedules aren't, kind of unpredictable. And so it's these tools that have helped groups, reduce no-shows, identify who those folks are, and then also kind of more effectively overbook. And then jump into the next slide. Just a quick snapshot of some of the impacts that a couple of federally qualified health centers have seen. One of these is in West Virginia, Family Care, another one down in New Orleans, St. Thomas. They have about 5% greater visit volume through this. And, of course, the revenue increase is dependent upon the size of the organization. That's translated into about a $500,000 increase from them. And, another key factor that's not here that we're really excited about is, more of their providers are doing overbooking. At first, some of their providers were just saying, hey, we just don't kind of trust the system. We don't want our schedules to be overbooked. We want to deliver that care, but we're conscious of being burnt out too. So now 50% more of their providers are doing overbooking, and so patients, providers, and the centers are doing a bit better. I'll just close out with one more slide. And it's just how we get this information to you. We understand that it's hard to jump around to different third-party portals. You already have your EMR, you're already juggling a lot of information. So we send this information to you just in a daily automated email that your care team can use to deliver these overbookings, and can immediately kind of decrease those lead times, can increase patient access. If groups are managing wait lists out there, this is a really good application for getting people off the wait list. So that's a lot of ways to, think about, hey, how do we increase patient access, and how do we identify those folks that, are more vulnerable? Deborah, I know no-shows are a thing that your group thinks a lot about, that a lot of the FQHCs you work with talk about. I'm just curious, have you seen groups that pay particular attention to no-shows and adopt solutions? Or do you think they're doing better with no-shows and getting, addressing those vulnerable populations?
Yeah, I think why no-show is so significant because of us now looking more at social determinants of health and how those attributes, those considerations, those things that sort of divert someone's ability to just simply get access to care, even though those services are in their communities. I think the fact that we are assessing based on SDOH, we have that technology, we have the ability to capture that information, but we're not now overlaying that with why are our patients no-showing. So that's why I thought your tool was such a great sort of idea to basically put the information in front of the stakeholders so that they can actually do something. They might see that there is something telling about that population that is the no-show. It might be common where they live. It might be common that they all have to take the bus. It might be common that it's a certain time of the month and therefore finances are not available for them to physically get there to those appointments. So I thought it was super important that we talk about the Prepare tool that a lot of our organizations are using to help understand some of the social constructs, the other things that impact life, and that life things get in the way. But also there's these issues of trauma. There's these issues of trust. These other pieces that are those non-tangibles that can also impact why these patients no-show. And if it's so easy to have that information in front of someone to investigate, why is my patient population not coming in? What an advantage that would be for the quality of life of that individual, because without having to say or repeat their issue or problem or statement, someone is looking at it and saying, I see you, I understand you, I know what's going on. And we're sorry because we're going to penalize you for continually not showing up. But we would do the same thing over and over, like booking you at the end of the month when your money might be running out. Why would we do that?
Yeah. I think that's a great point. I think that, with different FQHCs, there are kind of patient population level reasons as to why there may be no showing. Maybe it is, transportation is lacking in the area. And so it's important to know that on a population level and allocate resources there. But it's also important to go down to the patient level and understand, hey, does this person have specific trauma? Does this person have a specific need? So you want to be able to flex up and down, and you need to be able to store it in a place that's easily accessible, because a lot of times the data can be disparate, can store in different patient notes. And so just having, the information conveniently available is kind of the first step to changing things. Deborah, I think a question came in. Should I address that now or? Okay. Yeah, Wendy, so we do work with groups to develop kind of best practices around, stressing the importance of keeping appointments. I'll also say, it's important to give them options too. So, one of the things you actually shouldn't do is say, hey, keep this appointment and make sure you make this appointment. One thing you could do is say, hey, does this time still work? And if not, can we reschedule you for a better time? Because you'd rather have them reschedule 3 days out than say non-committally, yeah, I'll make it, and then end up no showing. So really you want to present the optionality and then let them choose the outcome that's best fit for them. I think you might be on mute, Deborah.
Sorry about that. We just have a few more minutes. Next slide. This is our Q&A opportunity, but we do appreciate those of you who have been putting questions in the Q&A and in the chat. And for those of you who still have some pressing questions after the session is over, we will leave the session open just for a few more minutes, just to make sure we can get to everyone. This is our contact information. So for those of you who have additional questions on general patient-centered medical home operations, you can reach out to me. You can also reach out to Anuja as she's presented. Those threshold questions and measure periods, definitely reach out to Anuja Solanko. Any questions on your revenue cycle management and how you can review and assess for that, reach out to Shannon. And Rachel is available if you have any questions looking at your ROI. Someone posted something very interesting about the HRSA incentives. And so ROI is pretty significant right now for those of you who are federally qualified health centers. And then obviously, if you have any questions about the streamlined no-show application, please feel free to reach out to Will. His contact information is available. But please continue to go ahead and put things in the chat. And at this point, if you do raise your hand and have a question for anyone on the session, you can go ahead and do that. And we will make it available for you to unmute yourself to go ahead and ask your question. So that is available right now as well. There's something else in the Q&A. Okay, so we do have a question, Anuja, from Ava. Can you please explain again about that 2024 collecting of SOGI data, gender and sexual orientation data?
Yes. So for 2023, it is optional, collecting gender identity and sexual orientation. But for 2024, it does become mandatory. There are some minimum options that need to be in the system. I'm happy to send those to you if you just drop your email in the chat, just so you can ramp up towards documenting that.
We had another question regarding resistance to SOGI screening, and they were getting some pushback. And I had asked, well, who's the pushback from, the patients or the staff? And it's the staff. And we know that. We know and we've heard, in fact, we just did a big, huge training initiative. We do have some resources on training and supporting your staff members on how to get that sexual orientation, gender identity information from patients as they come in. You can definitely reach out to me directly, DJ Ingram at PCDC.org, and I will share with you what our resources are available to support that. And additional resources. Again, we will definitely share. We have a whole free program on our website, and you can register. It has some additional resources on ROI. It has some additional resources on finance and financial literacy for staff members who are looking to become managers. It's called Small Practice Managers Essentials. Don't let the name fool you, because it's actually 10 most critical topic areas that everyone who is a practice manager, no matter where you are in terms of organization type, but they're very relevant topic areas. It is a free program. It is on our website. Just type in PCDC SPME, and you will find the link to register, and you can have your staff members go through all 10 of those modules, or whatever modules you think are appropriate. Unfortunately, we don't have the SOGI on there, but we will definitely, if you reach out to us, we will share some of those resources and what supports that we offer for staff SOGI screening support. And Wendy, we know who you are, so we'll definitely we'll answer that question. And it really is varies. We've had everyone from front desk work on that, and we've done training from front desk, nursing, and clinician. Again, it's about comfort level and ease of getting the information into the system, but we can definitely share some information with you, Wendy, on who should be collecting that information. We are at time. Again, here's our contact information. Feel free to reach out to us directly. We will respond. And we appreciate you guys joining us. And thank you for all. I appreciate the insight. Additional. Oh, this one was a question here. Kate, before we walk away. How important is it that health centers understand how it's incumbent on us to find solutions and not be punitive that further harms patients and exploits conditions? That's a whole other session, Kate. I love that question. I will definitely type my answer. I will definitely send you an answer, Kate. We'll find your email information. I will definitely respond to that. You guys have a wonderful afternoon, and thanks again for joining us.